Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, welcome to the program, everybody. And if you've been with us before, welcome back. And if you're brand new, we're glad to have you checking this out. And by the way, we want to let you know that we've been doing this show really for the enlightenment of people. And when we talk, because we record the show, but we love it when you give us input. And a lot of you have been doing that lately. And I'll give you a way that you can drop us an email or give us a phone call and get your concern aired on the program. And we do that from time to time. Today, I know that some of you have wondered how we're going to get our schools reopened. Well, welcome to class, because you are now going back to class yourself. It's a 6-class program. We're going to do a couple of them, 3 of them this week and 3 of them next week. And what this is, it's a 2-parter. So if you missed last time, we'll tell you how to go to the website and get it, to get the podcast, and also learn more about it. But basically, and this is like something that came along in Dr. Juliff's profession, that really changed the way that physicians around the world that specialize in vein and venous and arteries and all of that. It's amazingly simple now that somebody's done all the work of putting together a classification. So today, it's the 6 classes of venous disease, part 1 of 2, and we're actually going to go them from little teeny baby steps to, oh my goodness, I think I've got a big problem. But the good news is, Doc, that this is something that you can explain has been developed really kind of internationally. It's a code or a standard where somebody either new to the business or getting a patient that is not from their neck of the woods can say, well, I kind of know where this guy is already. We're going to be able, or her, we're going to be able to get a lot accomplished. Explain a little bit about what this is.
Yeah, well, it is. It's very much that. It's a way that we can communicate with each other, practitioners, people who are taking care of vein patients. But it tells us a whole set of important bits of information that allow us to not only communicate about that patient, but in also to describe the patient, but also it gives us kind of a starting point from which we then go with respect to treatment and how to treat, how urgently, how quickly, where to go, et cetera, et cetera. So it's a really nice system that does a lot of different things for us. And it hasn't been around that long. It's been around 15.
But since the 60s or 70s?
Well, probably no, not even that long. Maybe 15, 20 years. I think it was revised and. It's not a long-standing system that we use, but it's been very, very beneficial.
Well, one of the things that I found extremely important for me to learn, and I learned this a while ago, gang, because this is not my first rodeo. I'm learning more about this because not only do I facilitate the program for Dr. Juliff, but I'm a patient. And I'm not a very patient, but I can tell you, just like you learn about categories in hurricanes, and just like you learn in categories of cancer and a lot of other things, sometimes they're kind of even Steven. One step goes to the next, goes to the next. Some of these take a lot longer. In other words, somebody that has venous disease in their 60s may be at a class high up the chain, and somebody else can be in their 60s and just be starting. But once you start, isn't it sort of predictable what the next phases are probably going to be?
Yeah, it can be, because venous disease, unfortunately, is a progressive sort of process. Like most medical problems. But once you're on the road, it's hard to get off because usually it's a genetic kind of thing. And it's not like we can change our genes midstream. Once you get on the path. Now, there's a little variation with respect to how far along people will get. There's luckily it's a minimal number of people that actually go throughout the whole spectrum and get to very severe disease. So basically, what is this classification we're talking about? And you mentioned the classification of cancer, and it is very similar to that. A lot of people talk about stage 1, stage 2, and I think the lay people in general have had exposure in one way or another, either themselves or family members or whatever, and that the staging system for cancer is somewhat familiar. Yeah. So, I mean, most people know if you say stage 4, the that's flag goes bad.
Up. But, here's the thing, and I know this has been coming up a lot. We've talked about it, a while, and it looks like for a while the entire globe is going to be concerned with COVID-19 and other catastrophic, pandemics. And I know a lot of people that are patients of yours and have concerns about what, if any, correlations are there at this point between a virus like that and our circulatory system, because we already know that it's bothering people's respiratory systems, and they're finding out more and more that those are likely some of the long-term takeaways from this disease. Is there anything worrisome in your profession yet about possible complications based on somebody being COVID?
Well, unfortunately, there are. We are seeing thrombosis, blood clotting, in places where we don't want it, in people who are ill with COVID. We're always concerned about DVT, deep venous thrombosis, but unfortunately we're seeing thrombotic activity or blood clot formation, even in arteries, and usually smallish kind of arteries, in the people that are very, very ill. So, fortunately, we're seeing that kind of process only in the very ill with COVID. So we're seeing it in the ICUs, people on ventilators and all that sort of stuff. But I don't think the whole picture is completely defined with respect to ambulatory COVID.
Sure.
And are those people more susceptible to blood clot, DVT, et cetera, et cetera? They probably are, but it may or may not be a strong enough system or process that's really going to, make it significant.
Yeah, but it sure does scream loudly about being aware of how you're doing. Nowadays, if you start feeling a little funny, don't wait. Don't say, well, I can ride this out, because maybe you can't. Yeah. But I know that it hasn't affected it. What we're talking about, gang, here is something called CEAP, and it's CEAP. Yeah. And this is going to define what we're going to do this program and the next one. And so feel free at any time to write this down and to remember veinclinicsofhawaii.com, veinclinicsofhawaii.com, because once you've heard something on this show, calling into the office and saying, I just heard something last week and I want to know more about it. Boy, there's a ton of stuff we're going to send you. So that being said, I think the most important part is talk a little bit about the CEAP.
Yeah.
And then when does somebody find out at what stage they're going to be entering the fray on? Because some people, they wait a long time before they ever get looked at.
Yeah.
And they're way up the ladder.
Right.
Some could have been arrested 20, 30 years ago and wasn't.
Yeah. So, we called the CEAP system, and that the mnemonic is CEAP. Now, those 4 letters refer to 4 different parts of the classification system. The C stands for clinical, and what that means is, what are the clinical aspects of a patient at any one point in time. Basically when people come in, we evaluate them, with respect to the CEAP system. So we give them, the point on the continuum where they are. But wait, I found that to be relieving. Yeah.
When I was explained by you where I am, I thought, okay, I'm not at the end of the rope. I mean, there's a lot of maneuvering we can do here, and that's what we've been doing. But I think that if somebody doesn't get shocked into the reality of finding out where they are, if you have cancer, you don't want to find out at stage 4.
Right.
Because there are some things you can do to mitigate it. And I know we're going to talk about that here too. There's no pills. There's no automatic cure. it's something, if you get it, thanks to your mom and dad probably, that you're going to find yourself at some point in time somewhere on this chart.
Mm-hmm. Yeah. So anyway, the C is the clinical part of it, and that's basically what does that patient look like? What do they have superficially? What do they have when we look at them with the ultrasound, et cetera? So the clinical part of it is really the part that we use the most with respect to just talking about patients. And that's what we're going to go through today. We're going to talk about the various, the various clinical phases, and today we're going to talk about the first three. There's a total of 6. C, and we call those C1 through C6, and that's how we refer to people. There are C1, C4, whatever. So that's the first and the most useful and most used part of the whole system. The E stands for etiology. So, we also like to define why. Why does this person have vein disease? Why are they suffering from the symptoms that they have related to their venous system? And the etiology part of it, we kind of break down into primary, secondary, and congenital. So, what is primary? Well, primary just means that primary is kind of run-of-the-mill, the run-of-the-mill type of venous insufficiency. Venous reflux has to do with failure of valves. We've talked about that. We'll talk about that a little later also in this hour. So that's the primary. Secondary means that they have venous insufficiency due to something else. Either they had a DVT. If somebody has a blood clot in their leg, well, there often are going to be negative repercussions with respect to venous function. And so the etiology for those people having poor vein function is a secondary etiology, and it can be DVT, it can be trauma, it can be surgery, all sorts of things. And then the third type of etiology is something that we call congenital. And, some people are just born with, vein problems. We've talked a little bit about that before on this show, and we won't go into too much depth right now. But, basically, people can be born with, for instance, a lack of valves, and therefore they have no valve function.
And by the way,
that's a problem.
I did talk to a listener who apparently has a son in his 30s. One leg, not a problem. Nothing.
Yeah.
The other leg, no valves.
Right.
So obviously he got shortchanged in the valve department.
Yeah.
But the guy's still walking around and doing pretty well. But it has cost him the ability to stay on his feet now that he's working. He's a stand-up guy. He's a sales guy.
Yeah.
And he's all day long. As long as he's got customers, he's happy. He said he really starts feeling morose and pained when there's nobody around, there's nothing to do, and he realizes that he's in pain.
Yeah.
I know you deal with that a lot.
Right. Well, luckily, the congenital part of it is the least likely. There's the least number of patients out there with congenital venous insufficiency, and I say that's luckily because of the fact that usually those people are fairly complicated, hard to deal with respect to trying to improve their venous status as much as we can. They're very challenging patients. I mean, there's no question about that. So that's the C and that's the E. Then the next one is A. A has to do with the anatomic part of the classification, and basically that just refers to which set of veins is the problem in. And there's two different systems of veins. There are superficial veins, there are deep veins,
and the deeper ones, right?
And then there are veins that connect the two systems. Those are called perforator veins. So, and we can have problems, we can have similar kind of problems in either sets of those veins. We can have problems in just one set. We can be just in the superficial venous system. It can be just in the deep venous system. Usually it's either one or the other, but not uncommonly we see people that have problems in both.
Sure.
And so they just need a little more attention, but we're able to define that completely in the process of our workup and defining what they have.
Yeah, and I found something really, really interesting personally, and that was when you say anatomical, I always think of the medical books you see when you're in school. And we've talked on previous programs on how much is going on in your legs.
Oh, yeah.
I mean, when you open one up, excuse the expression, but when you take a look at a blown up drawing of an illustration, I can't believe last show we were talking about this, remember? And I saw this thing and I thought, my goodness.
Yeah.
Thank goodness for ultrasound and thank goodness for good vision on good doctors to get in there and figure out in all that mess what in the heck is related to what and how do we fix it?
Yeah, there's a lot going on. Our extremities are not as dynamic. I think sometimes people feel as like looking inside the chest and looking at the heart and the lungs and all that sort of stuff. But there's a lot going on within an extremity, and therefore a lot that can go wrong. But luckily we can take care of it most of the time. So the fourth part of the SEEP classification is what we call pathophysiology.
Oh boy!
And that just means what's the pathology? What is the medical problem that occurred that is creating this disease process within the veins? And basically that just means, is it reflux? Two different things there, reflux or obstruction. And, reflux is, again, sort of the run-of-the-mill kind of things that we see in most patients day after day. Their valves are failing, blood's going in the wrong direction, and that's what we call reflux. And, again, that can be in the superficial or the deep system. But if it's not reflux, then the other possibility is obstructive. And obstructive can be due to either DVT or some other inflammatory. Again, there's a whole host of things: infection, inflammation, other mechanical processes going on around the vein, not necessarily due specifically to the vein. Sometimes other blood vessels are impacting a vein, and it can cause an obstructive kind of process, and then lead to venous disease.
To me, it's interesting how technology has launched itself smack dab in the middle of this, because this is relatively new. And I was talking to a guy in charge of the auto and body and painting shops of Hawaii for car repair, and every single desktop now has a desktop on it. I mean, and it used to be that you'd have a manual, a repair manual. Yeah. And I guess back in the days, your medical journals and your medical books, that was a repair manual. Sure. But now there's videos, and there's everything. Right. And there's absolutely everything. And I'm guessing that some of those things that have come along have really aided in this SEEP process to really make not just a practitioner, but somebody comfortable. I don't want to say that you ever get comfortable when you have a physical problem, but tolerable. I am now not willing to not do what I want to do if I know that it's something to do with not wearing my stockings or not getting enough rest or that stuff, because it really is, it can make a big difference. But it matters, and that's why this thing that we tell you about, gang, our mailbag. So if you've got anything going on with you as we go through this program, at any time, and you hear something that sounds like me, boy, that's the door. That's the key to get in there and find out what's going on. And that's why we wanted to do this 2-part show. Yeah.
So that's that in general. That's the kind of a overview of the SEEP system. But so the next question is, why do we need or want a classification system? We've touched on a little bit already, but the first thing is it's a way for us to imply severity. How bad is the venous disease process in any one person? Is the process just starting? And we can kind of take our time and look at exactly what's going on, and in a leisurely fashion, figure out what can be done to avoid it progressing in the future, or is it bad enough to say, gee, we need to intervene in the short term? Or is it so bad that we need to do something right now? Yeah. So where people lie on that the classification system gives us an idea about how severe their disease is, and then basically that implies urgency of treatment.
Yeah. And by the way, gang, that's what I'm going through as a patient. Some of the things that I'm doing are fun, and because so many people ask me about things like spider veins, which we're about to get into in a bit, and all of that, and it's fun, because if you have these things and you don't like them because they're ugly, like the commercial said that you heard when we came on today, when they go away, it's like, wow. And that's why I think knowing where I am on this thing becomes valuable, because I do know that a lot of times, you want a treatment, but you don't really relate the symptom as being a venous problem. It's I'm just my aching back, or I'm getting older, I twisted myself, or I got a sunburn, that's why my leg is red. All of that stuff goes away when you find out about the seat, where you are. About these
It's even a little better way to define the problem, not only for us, but for the patient.
patients,
and basically, that's what you're saying. So when a patient comes in and they say, "Gee, we have this and we have that," and we do an ultrasound and we find out exactly what's going on inside their leg, then we can put numbers on it, and I think that, as much as anything, kind of hits home with people. If you can put a number on it,
exactly.
One is the least and 6 is the worst, then it all kind of makes sense.
It does. And gang, that's where I need you to be. Because I can tell you right now that, first of all, if you've listened, 20 minutes into the show, we got you. I mean, you're somewhere along. Nobody actually listens to us a whole bunch that doesn't have either a problem themselves or a loved one. Because I got better things to do with a Saturday or Sunday, as you do too, as to talk about something that's not relevant. But this is so relevant. Because so many of us are looking at ways to extend life and go on vacations and do things. And a lot of us that have venous conditions are not able to travel because of the problems associated with having the disease.
Sure. Yeah. Well, maintaining good vein health in your legs is a part of, maintaining good overall general health. And I think the important thing there is that, venous insufficiency and venous disease is such a common problem that when you look around, 50% of adults, nearly 50% of adults have some amount of venous insufficiency. So, if you're just sitting across the room from somebody, either you or they have it. Yeah. So, that's and again, it should be a general part of our overall health maintenance, kind of knowing if you have it or not, and doing things that you can to optimize the venous function of your legs.
And guess what, gang? There's been one patient of Dr. Julips, I haven't even told him about this yet. He can't wait for the pandemic to be over because he wants to go to the beach and show off his legs. I mean, because we've not been doing these things for a long time.
Sure.
And I guess that once again, that's why we want to do this and get into it, because it really, really does help. And I'm not saying that ever vein care is a game, but it certainly is a challenge, and there are certain things you can do to make life a lot better. We're going to learn about some of them.
Yeah. So the next reason that we like to use a classification system is to be able to communicate about patients. Not only communicate with patients, but communicate about patients with other doctors that might be taking care of them, with other vein specialists in other parts of the country where maybe they're going or they have come from, especially in a place like Hawaii where people are traveling all the time. So it's so much easier for us to say, oh yeah, we saw your patient, they're C4, and we're doing this and that, and so it's nice to be able to do that. It's also nice to be able to use that classification system in studying patients. There is a vast amount of medical study that's going on all the time about every part of medicine, but and the same goes for venous disease, and it's a good way to sort of categorize patients and study them to see the effect of our treatment on specific classes.
And I got a couple of real quick questions about that. I don't want to deviate too much because we do have a lot of ground to cover. But that is, every now and again you lose a patient because they are going to permanently move.
Sure.
And they're going to want to have their bundle of parting gifts from Dr. Julev.
Yeah.
And the same thing happens here. By the way, Vein Clinics of Hawaii started on the Big Island, 4 islands: Maui, Kauai, the Big Island, and of course here on Oahu. It's all veinclinicsofhawaii.com, veinclinicsofhawaii.com. But it is really important because I do know that somebody goes in there and says, Dr. Julev, nice to meet you. I'm Mike, and I used to have Dr. Smith in Memphis, and now I have you because he told me about you, and here's my stuff. Let's get started. I don't want to interrupt my treatment.
Sure. Yeah. Absolutely. Yeah. So the other reasons that we like to use this classification is because it does direct treatment to a certain extent. I mean, if we have a classification of 2, and that gives us a very good idea about where that patient is on the spectrum, and it kind of implies to us what we need to do and how urgently we need to move forward with it. Another important thing is tracking the response. of treatment. So, like I mentioned before, every patient that comes into the office, when we do our initial assessment, when we do we take their medical history and the complaints they have, and we do a physical examination, and we evaluate how their legs look. We do an ultrasound, and that gives us a tremendous amount of information with respect to the anatomy and the pathophysiology, et cetera. We come up with a full SEEP classification for every patient. So we know that that's where the patient came to us in, and so we are going to then embark on evaluation and very likely treating them. And it's good for us to know, and the patient also, to know that, when they come out on the other side of it, their SEEP classification is better. That's one of our goals.
Okay, so now gang, the value of this. It's like priceless. And now we're going to sort of start ramping up into, now that welcome to the office, fill out this thing. At Dr. Juliff's office, everything's great. Social distancing, all the stuff that you expect right now is definitely taking place. But in addition to that, you get the temporary use of an iPad, which can help you a lot, because that is a pretty comprehensive way to get on find out we're in the CEAP, MI, and that's how you can determine that right after you see my stuff.
Mm-hmm. Yeah, that's a big part of the SEEP. I mean, the information that the patient gives us on our iPad, and then that all kind of goes into the system, and then our our history and our physical examination, that information goes into the system, and then the ultrasound findings that goes in, and the electronic medical record system that we have automatically then generates for us the SEEP classification, and it's really cool. It's very nice.
You know what I love about it, gang? You can say, send me a picture of that. Boom, here you go.
Yeah.
I mean, They used to be, we'll mail something to you. Get there in a month, maybe. But golly, this is great.
Okay, so getting into the system now, like I said, we're gonna talk only about the clinical part of the SEEP, classification. That's the one that I think that we utilize the most in just thinking about the patient. That's the one that we utilize the most in talking to other doctors and et cetera, other practitioners about patients. So that starts out, it's C1 through C6. And as that number implies, C1 is the least, I guess, the least severe. C6 is the most severe. But basically, people who come in and they have what we call C1 disease are those people with spider veins. Spider veins only.
I call them the newbies.
Yeah. So, so why do spider veins occur? Well, spider veins occur for two reasons. Either they're sporadic, we don't really know, we can't define a reason. I think before we go into this, I think that it would be beneficial to say that, spider veins, we look at spider veins, and basically everybody looks at spider veins primarily as a aesthetic problem.
Right.
It's a cosmetic
it's a beauty
issue.
It's a cosmetic deal.
And it doesn't, because it's not, if all you have are spider veins, it's not altering your venous function overall. It's typically not having significant symptoms, although some spider veins do. So anyway, spider veins are considered cosmetic, but why do they happen? Well, they happen sporadically. Like I said, we can't really define a reason, or they can be genetic. People come in all the time and all they have is spider veins, but they say, oh yeah, my mother, my grandmother, I've got all, my aunts, et cetera, et cetera. So, why do we even worry about spider veins? Well, spider veins, some people just want them treated.
I know why.
Because of a cosmetic.
Because I'm vain. And if I got veins that you can see, I don't want you to see them anymore. But I get it. And I do know that there are a lot of people, particularly in professional areas, that the least obvious things that are sticking out on their body, the better.
Yeah.
And we're talking about, particularly here in Hawaii, Doc, as you know, on all your islands and all your clinics. A lot of our folks they work around swimming pools, they're waiters, they're waitresses. These are people, these are the movers and shakers, and they don't want to be, what's that thing on your leg? They want to get that fixed.
Yeah. And spider veins are very, very common. I mean, the majority of people probably have some amount of spider veins. You know, some studies show that 80 or 90% of people have spider veins. And I mean, just looking, you know, when you're shopping around, you can see, you know, veins on most people's legs. It's unusual to have somebody, especially once they get to be 40, 50 years old, that don't have spider veins, quite frankly. So is this a problem of just the legs, or can it occur on other parts of the body? Yes, it can. It's a little different, as all veins, you know, we consider all veins to be a little different in the legs because of the, you know, the physiology of the venous system of the legs. It's a little different than everywhere else. But, you know, spider veins also show up on the face.
Sure. Yeah.
And, you know, people find those very aggravating. Is it the same process? Well, it may or may not. It's not a part of venous insufficiency.
I got to tell you something. My dad said to me one time, long time ago, at a family picnic on the beach. And I just had, I think I was like 13 or 14, and I just had a big belt of a beer, you know, and with his permission, of course. And he says, now that's all you're going to get, because you don't want to look you don't want to look like Uncle, because Uncle had one of those faces, and this big happy Irish Hawaiian guy just had this face like veins all over the place. It didn't bother the guy, but you know, and I guess some of that's complexion related, and some, I mean, I guess, isn't it more obvious if someone is fairer skin?
Oh yeah,
but it happens to everybody, right? They're there for everybody.
Well, it can be again, it's kind of like on the legs. I mean, very little spider veins on the face are very, very common. You know, most of the time it doesn't matter to you people. But so so what are the symptoms? You know, do spider veins cause symptoms? And you know, typically we think of spider veins as not, you know, necessarily causing significant kind of symptoms. But, you know, just I know from my own experience in the office, seeing a lot of people there, it's not uncommon for people to, you know, come in and say, gee, you know, I've got a lot of achiness right in this area or wherever, you know, specifically where they have the spider veins. So I think sometimes probably spider veins can cause symptoms, but I think in the majority of cases they do not. So,
yeah, and that's an elective process, gang. You can do whenever you want. I just had some interesting stuff done to the top of my feet just because I was looking at these veins. Doc, can we just, we'll take it, and they're gone. I mean, that's the kind of a thing that you expect to have. But that's, so in other words, it's welcome to the world of venous disease. You have the least harmful part of it right now, but let's take a look at the rest of you.
Yeah, right. Yeah. So the next question is, and it is always for us when people come in and they're saying, "Gee, I have spider veins," you know, do these people need to be evaluated? And sometimes they do, sometimes they don't necessarily have to be evaluated. And by that I mean do an ultrasound and you know
get a little more thorough.
Consider whether they have underlying venous insufficiency, because you know sometimes they do, sometimes they don't. So at that point, we typically, you know, that's part of the history that we take from the patient. You know, do they have symptoms? You know, do they have the typical symptoms of venous insufficiency like achiness, heaviness, fatigue, you know, muscle cramping, restless leg, swelling in the legs, etc. You know, do they have the symptoms that we would, you know, normally identify to be associated with this process that we call venous insufficiency? And again, some people do, some people don't. Do they have other signs of venous insufficiency? You know, some people will come in with you know, spider veins and be you know, specifically concerned about, you know, new spider veins popping up on their legs, but at the same time they can have like you know, varicose veins and other things going on that are obviously you know, a part of venous insufficiency, but they're more focused on the spider veins. So you know, we take a history, we look at their legs, and we see if there are other signs, see if there are other symptoms that would imply the process of venous insufficiency. If they do have those symptoms, then typically we say, yeah, we should probably look at your legs with an ultrasound and see what's going on. And then we describe what we mean by venous insufficiency, and we talk about the fact that, you know, venous insufficiency has to do with the vein function of the veins that are deeper in the leg, And can spider veins be connected or associated with that process? Absolutely.
Absolutely.
Can people have spider veins because they have venous insufficiency? Sure. I mean, it's part of the whole process.
But what I do like about that, Dr. Julep, and by the way, Dr. Julep is the medical director of the Vein Clinics of Hawaii and available at veinclinicsofhawaii.com. And anytime you have a question, it'll get into one of our mailbag shows. We're going to be doing that again in another couple of weeks. But I think that, therefore, when we talk about that, it's sometimes you're very, very lucky. But I got more people talking about how when they have their wife or their daughter or themselves get treated for spider veins, that their overall countenance and they're feeling of good. They're willing to be extroverted and not hide.
Feeling of well-being.
Yeah. And that is self-esteem is a big deal.
Oh yeah.
And it's for me too. I got spider veins. They're going away because I don't want them anymore.
Yeah.
But only because I think I don't want to give anybody anything to complain about. I want to be okay. But you know what I'm getting at.
Well,
Self-esteem
absolutely.
is really a big deal.
Yeah. Even though unfortunately insurance companies don't consider it a medical problem,
Shame
with
on
spider
them.
veins.
Yeah, shame on them.
From a mental health or a psychological or a sense of well-being or self-worth and all that sort of stuff. Oftentimes, it is very important. I can't tell you. I mean, every day of the week, we have people who come in and say, "Oh, I haven't worn shorts for 10 years,
because
20
of this.
years."
Yeah.
Because of veins on their legs, and it can be something as simple as spider veins.
Yeah.
Now, I just can't imagine that, but that's how much it can impact the quality of life of some people. So,
hey, listen, gang, I had a big one on the top of my left thigh. It was about as big as a volleyball, and it was a spider web, and it was a thing. And I can't tell you, the daughter and then granddaughter, Papa, what is that? Well, it's gone, and so she can find something else to complain about, but not that anymore. But you know what? I must tell you that I'm not sure that I had self-esteem problems because of the business I'm in. It'd be pretty tough, but I can tell you that it did make a difference. That I did feel better once that area got treated.
Sure. Yeah. I'm convinced that it's tremendously beneficial for so many people, and again, it really goes to their quality of life, and that's why we do most things is to improve people's quality of life. So there's another issue that can arise with spider veins. I mean, spider veins are usually a cosmetic problem, but can they be more of a medical nuisance or a real medical problem? Yeah, because sometimes they bleed. Yep. And, we've all heard the stories of people, with a little vein on the lower part of their leg and it, lets loose and
panic.
It can be a major problem. Yeah. So, why does that happen? Well, usually it happens in people who are a little older, who have very long-standing vein problems. It's the people that we see, urgent or sudden bleeding, spontaneous bleeding from are not, mid 20-year-old, women with a few little spider veins here and there. That's not the population of people we're talking about. Typically it's older people. It can happen to men or women, and we treat people. We treat both genders all the time for spontaneous bleeding from spider veins, and usually it's from longer-standing venous insufficiency because for some reason some spider veins, and it tends to happen in some people more than others, and I'm not quite sure why.
Also, how come every now and again it decides to happen when you're in the shower?
Yeah.
And maybe it's hot water or maybe it's standing up or all of the above. But I do know that instead of running to the ER, you just sit down and raise your leg up. It's going to be all right.
Yeah.
That's amazing.
Well, and that's the typical scenario.
Yeah.
I treated a lady today who said that exact thing
Poor
happened.
Thing. It happened to me, so I'm not laughing at her. I'm laughing with her.
Yeah. So, I think that long-standing, venous insufficiency is going to create an increase in pressure within all the venous system, but it will then be transmitted more superficially to the, more superficial veins. Most of the time, we see dilatation, we see superficial dilatation of larger veins, and we call those varicose veins. But sometimes that increase in pressure can lead to dilatation of these tiny little spider veins, and what happens is the skin starts to thin out over the surface of those veins.
That's what it is.
And then as that skin becomes thinner and thinner, then people go into the shower and they've got the hot water running over the skin, and I think that makes it even a little more fragile. The skin a little more fragile, and then the skin breaks and that vein lets loose.
Can the same thing happen with a little trauma, a little
they get
a little
absolutely.
bang or a little bump?
Sure,
Into something.
That happens too. So what do we do? Well, we basically what we don't do, what we recommend to people that they don't do is panic, run, and spread blood all over the place. But if they lay down, especially if hopefully they have someone there, they can put pressure on the area, elevate the leg, and typically it's going to stop. So what do we do for spider veins? Well, basically we do injection sclerotherapy. We get a pretty good result. We can make things look quite a bit better for most people. We can't make everything go away. Most of the time I tell people, listen, we can't cure you of your spider veins, but we can help you manage your spider veins. And again, we can do a pretty good job.
Yep, works for me, gang. Just at it again. It's magic. Yeah.
Okay, so moving on, we go to C2. Clinical category 2, and that basically has to do with varicose veins. And what does it mean when somebody has varicose veins? Does it mean something more than just spider veins? Well, most of the time it does. Most of the time why that is occurring is because people do have that process of underlying venous insufficiency. And why do people develop varicose veins? Well, because of the process of venous reflux, getting back to valve failure. There are many little one-way valves in the deeper veins within our legs, and that maintains blood flow in the upward direction back to the heart,
which is where it needs to go.
Which is the correct direction. As those valves fail, then the blood starts to move downward, and that creates something that we call venous insufficiency. Now, that downward movement of blood is then going somewhere, so it's creating an increased pressure within the entire venous system. And varicose veins are not, varicose veins start out as normal veins. They're just normal subcutaneous, veins that we have all over our body. But with that increase in pressure, as the blood starts to settle into the leg, and as the blood is not flowing upward the way it should, then those superficial veins are subjected to that increased pressure and downward flow, and then they dilate over a long period of time. I mean, it doesn't happen overnight. So what are the risk factors of venous insufficiency in general? Well, most of the time there's a genetic component. In most of our patients, we will find that they, either a mother, father, grandparents, or whatever. So most people have a genetic component, but then there are lifestyle things that then will kind of function as an additive kind of process to either make the disease process worse or make it progress, et cetera. And usually we see a little bit higher incidence of venous insufficiency in women, and that's because of the fact that they have multiple pregnancies, or they can get pregnant. We see it more so in women with multiple pregnancies, and then also just kind of hormonal changes that happen in women, but obesity, age, various occupations. The people who are on their feet a long time throughout the day, those people are at a higher risk for developing venous insufficiency and then ultimately varicose veins.
And Doc, if you take that and you learn about it, that it's generational. I would imagine that there are some people that are talked to by their families saying, I know that you're hell-bent on wanting to do that for a living, but that may not be a good idea for you. And I know that sometimes people will do during the course of their treatment, have a big brain flash and say, hey, you know what? I don't want to irritate this at work. I'm not going to do that kind of work. I'm going to do something else.
Yeah. Well, if they have that choice, that would be great.
Yeah. Absolutely. But a lot of people don't. You're right.
Yeah, a lot of people don't. But or the other thing is that, let's say you want to be a hairdresser. Now, we see hairdressers all the time because they are on their feet every day, all day long. So if you are someone who is going, wants to be a hairdresser, or you're a pharmacist or a nurse or whatever, if you have a family history of vein disease, then you probably need to be a lot more conscientious in doing things that will help you avoid it in the future if you want to. And the first thing, obviously, is compression stockings, as we always talk about.
Yep. Well, we made it 40 minutes into the program before we did that, but it's true, and I'm wearing mine right now. But this also includes other professions, gang. Those of you that are in the culinary business, you love being in the kitchen, you're under that heat all day, you're standing up, you're a waitress, you're a maitre d', you're seating people at tables, all on your feet. A lot of people doing that.
Right, yeah. So if you have varicose veins, should you have that looked at? My answer, my general answer to that is yes.
I would hope so. That's your business.
You should. Yeah.
But gang, look you have choices, and you have to. This is where you might learn to make them. That's why I want you to go to veinclinicsofhawaii.com, because once you understand that the difference between spider veins and varicose veins, if you leave them unattended or untreated or unexamined for a long period of time, it could get bad.
Yeah. Oh, yeah. Well, definitely. Yeah. That's the crux of the problem. Is venous disease usually just gets worse with time. If you have varicose veins, does that mean that you have venous insufficiency? Well, most of the time it does. Yeah. So, to the question of should I have it looked at, a fair amount depends on symptoms. Now, a lot of people feel like they're not having symptoms, due to their varicose veins, but sometimes they don't know what the symptoms are of varicose veins and venous insufficiency, and that's why I say, yes, come on in and talk to us so that we can kind of evaluate you, completely and fully and talk to you, get an idea about whether you're having symptoms, and again, put you on that classification, spectrum. We put you on the SEEP, the spectrum, so that we know exactly how severe your situation is, how urgently do we need to consider intervention or just conservative treatment or whatever. But if you have varicose veins, at the very least, you need to be advised on conservative therapy for varicose veins. And
by the way, that's long before you're talking about surgery. There's a lot of things you mentioned, compression stockings and some of the other things.
Right.
But is it a slippery slope? I mean, once you're there, unless you do something, you can't just sit there and say, "Well, I'm going to get lucky," or not.
Yeah, no, yeah, and that's basically what what happens in general is that people with varicose veins will eventually get to the point where they need some type of intervention because again, it's progressive. Number one, number two, it's a mechanical problem. Yep. It's a problem of those one-way valves that are failing, and it's not that problem does not get better, by wearing compression stockings or by exercising more or by eating differently or whatever. So usually it requires a mechanical fix in one way or the other. So what are some of the bad things that can happen because of the fact that you have varicose veins? One is just symptoms. I mean, people have symptoms.
I'm sick and tired of feeling sick and tired.
Yeah, symptoms from not only the varicose veins, but also the venous insufficiency. And then there are other things that can happen. There are things like, blood clot formation. Which some people with varicose veins will develop what we call a superficial venous thrombosis. Now, is that life-threatening? No, hardly ever. But is it an aggravation? Yes, absolutely. And can it happen, time and time again? It can. Those types of episodes are one of the things that would, push us more toward recommending intervention. But probably more importantly is that, people who have varicose veins and venous insufficiency have a much higher incidence and a higher risk of DVT, deep venous thrombosis.
That's the one that we're learning on late night television to be very careful about. And every now and again you hear about that, Doc, when somebody goes thousands of miles away on vacation and has a problem in the hospital and doesn't come home.
Right. Oh, absolutely. Yeah. DVT it can be a fatal problem. Yeah. And not uncommonly in the scenario of, travel, people are on a plane for a long period of time and they develop a blood clot and then they go on, with their vacation and, can lead to disaster sometimes. So that's one of the other reasons why I recommend that people with varicose veins, we really need to take a look at them. Let's do an ultrasound. Let's give us an opportunity to kind of listen to you and see what your symptoms are, and kind of make an informed decision.
Okay, so here we are, getting towards the end of the program, just in the perfect time to be my number one concern. It was when I went to see Doc, and it still is, and it's being handled, and that is all of the different things can be indicated when somebody is swollen. Isn't it?
Yeah.
Even the word swelling makes you feel bad. Why is swelling so associated with varicose veins as well as other conditions?
Yeah. Well, in swelling indicates the next classification, that's C3. And, the movement of a patient from C2 to C3 is, in my mind, fairly important because, now we're talking about a little higher level of, venous disease and
symptoms.
And a little more urgency in finding out what's going on and doing something about it. It's often a part of venous insufficiency. It indicates a little higher level of venous insufficiency. Why do some people have it and others do not? If they have venous insufficiency, I don't know. Probably has to do with the chronicity of the process. How long has it been going on? It's kind of funny in my experience. There are people who come in with long-standing venous insufficiency and varicose veins. Then another group of people that come in are those people that have venous insufficiency and long-standing swelling, but they often don't have a lot of varicose veins. So, it's interesting to see how that happens, and it's just something that I've observed over the years. But does someone with swelling absolutely have venous insufficiency? Well, no, they don't. But often it's a part. There are other reasons why people have swelling. It's not just venous insufficiency. One of the other causes for swelling is something that we call lymphedema, and that's something that we've talked about before on the show. Lymphedema is something that goes very much hand in hand with venous insufficiency, but some people have just lymphedema, and there isn't a venous component to it. Swelling can be due to heart problems or kidney problems. They can be due to, fluid and electrolyte imbalance or other metabolic abnormalities. So it's not always, just related to veins, but but venous insufficiency often plays a role in swelling.
I kind of get it in my own case as swelling in many respects. I hate to say this, but it's a good thing because it's a sure bell ringer that, hey, why is that swollen? And after 3 or 4 days of doing this and doing that, and it's still swollen, you know what? I'm going to the doc.
Yeah.
It's just time.
Right. So, edema or swelling is one of those things that can be a little frustrating for us at times because, people come in with swelling and they want to get rid of it. They want to get rid of all of their swelling. And, so again, we go through our usual evaluation and ultrasound, and often we see those people. They do have venous insufficiency, and we fix their venous insufficiency, and we hope to get as much improvement as we possibly can. But sometimes there can be some residual swelling, and we handled that in whatever way is the most appropriate after we have corrected their venous disease process. And again, often lymphedema and venous insufficiency go hand in hand so often, and I think we're as the years go by, we're learning more and more about lymphedema and how to handle it. Luckily we've got a lot of conservative ways that we can correct that also.
Yeah, And so that's kind of our time to tell you. First of all, you did really well. You paid attention. You did the right thing. Like, we could see you nodding out there, and we could see you making questions. And if anything that we've talked about today gets you curious and you want to know more, perfect. Go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. And if you like this, and even if you didn't like it, if it just gave you a harsh reality of where you are, part 2 of this program is next week. Same time, same stations. And tell others that may be involved. Hey, you know what? I heard a really neat radio program, and there's going to be another part of it. We promise we will go to the beginning of that show next week, and we will sort of recap where we went today. But for everybody at Vein Clinics of Hawaii and Dr. Juleff, I'm Mike Buck. Thank you so much for listening, and please do come back and see us again. And remember, to know more and to get a question on our mailbag, which will show up on one of these shows, go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.